I'm Dr. Valeria Duarte. I'm one of the adult congenital cardiologists and cardiac imagers at the Houston Methodist. Today we're going to have the second part of our congenital heart disease lecture series, and we will discuss the general approach to complex defects. It's very hard, as you know, to cover all the complex defects in 1 hour. So we will focus on one of them, the loop transposition of the great arteries, and we will use that as a framework to approach all the other defects. So as we always discuss, in congenital heart disease, we have some key principles that all my fellows know. So it's very important to, before we protocol in imaging study for congenital heart disease, that we take into account the native anatomy. We review the different surgical repairs for each condition and determine which one the patient had. And then that we actively search for long-term complications of each condition and surgery. That we take advantage of the strengths of each imaging modality, and I'm going to do something different today. I'm going to try to alternate echo, MRI, and CT for different purposes. Hopefully it won't get confusing. And then review the surgical history of the patient, get the operative reports. Sometimes we need to postpone the imaging date just to get the appropriate data before getting the patient to the scanner. And then talk to your referring physicians, ask what is the problem, what's going on, what are the symptoms, what are they looking for, what are they concerned about. Sometimes they found something unusual in routine testing and they just want further detail. And if you're imaging a patient for the first time, rethink the anatomy. It's important to review all the reports and notes and everything, but just remember that some patients, adult patients, were diagnosed at a different time, many years ago, and the imaging resources were very different back then. So don't be afraid of restructuring the anatomy with the newer, with contemporary imaging. And then whenever you report, use language that providers from different backgrounds, pediatric and adult cardiology, can understand. And sometimes that means repeating the same thing several times with different names and nomenclatures, but that's just the nature of congenital heart disease. So the ACC/AHA guidelines for the management of adult congenital heart disease provided us with this great classification, and we'll just touch on the anatomic one. So the conditions that are included within the great complexity CHD are cyanotic heart conditions, double outlet right ventricle, Fontan, interrupted aortic arch. All the single ventricles, as you all know, the very different anatomies can lead to a single ventricle physiology, pulmonary atresia, transposition of the great arteries, D-loop transposition, and also L-loop transposition or congenital corrected transposition, more appropriately, truncus, and then all the heterotaxy syndromes that my MRI fellows are so fond of. So let's get started with D-loop transposition of the great arteries. So this is the normal segmental anatomy as per the Bank-Prague classification. So 3 segments, right? The atria, the ventricles, and the great arteries, and these are the usual connections. So in contrast, let's review what happens in D-loop transposition. So in D-loop transposition, the segmental anatomy is SDD as opposed to SDS. So as you can tell already by the nomenclature, the first 2 segments are aligned as usual. So when you image patients with D-loop transposition, the atria and the ventricles are in their usual position. The LV is leftward and leftward and to the back, and the RV is anterior and to the right. So that works as usual. The problem is, so we have AV concordance, right? Atrioventricular concordance. The problem is in the ventricular arterial arrangement, right? We have a ventricular arterial discordance. The LV is connected to the PA and the RV to the aorta. So that's a problem here. With this, the aorta receives blue blood from the systemic right ventricle. So these patients, these babies are born very cyanotic with saturations in the 50s. The survival without repair in D-loop transposition it's very, very low, except in patients with some specific large VSD and pulmonary stenosis, but we won't discuss that. So these patients they need an urgent intervention. Patients without a VSD, without mixing, they need an urgent intervention right after birth. And they need an emergent ASD creation, and this can be done surgically or a transcatheter. So anybody remembers what's the procedure, the transcatheter ASD creation called? Who developed it? Rashkin, that's right. Yahir just graduated from his congenital rotation. I'll take all the credit. So that's right. Okay, so this is just what this is a cardiac MRI. You can see this is morphologically a right ventricle, right? And you all know how to recognize this, right? The morphologic right ventricle. We cannot see those features here, but we have AV valve attachments to the septum, right? As opposed to the LV that has a smooth septal surface, and we have a moderator band, trabeculation. So here you can see a very hypertrophy systemic right ventricle, and you see an aorta that is anterior to the pulmonary valve and the pulmonary artery arising from it. And you also can see another key feature of D-loop transposition for your boards, that the great arteries look parallel. So let's look some more. So this is a similar image illustrating the same thing. This is the right ventricle here. The aorta rises anterior and to the right in D-loop transposition to the PA, and then the LV, the PA arises from the subpulmonary LV. Sometimes we need to look for obstruction here too. Okay, so what are the operations for D-loop transposition? Can you guys help me? Louder. The atrial switch, that's correct. The atrial switch operation, thank you, Jessica. That was the first surgery described for D-loop transposition. It was performed by Dr. Senning in 1958 and Master in 1964. They're both atrial switch operations, but they're technically very different. The Senning operation involves creation of baffles using autologous tissue, atrial tissue of the patient. It's like an origami. It's a very hard operation to perform. The Master operation also creates baffles, a systemic venous, and we'll describe those in a minute, and a pulmonary venous using prosthetic material. So what's another operation for D-loop transposition? Oh, right, that's right. So the next one is the arterial switch operation, which was developed by a Brazilian Lebanese surgeon. His name is, and Isa has taught me how to say this right, Ajivi Jateni. That's right? Did I say it right, Isa? Sort of, okay. How is it? Teach us. Jateni. Got it. Okay. And then also the other one is the Rastelli procedure for selected patients with the constellations of defects. So let's go back to our diagram. So normal segmental anatomy, D-loop TGA, we're all familiar. So we'll first describe the arterial switch because it's just more straightforward. So if the great arteries are flipped, are transposed, intuitively the easier thing to do is to just connect the right ventricle, the right ventricle to the PA and the LV to the aorta. So this was very challenging because it involves reimplantation of the coronary arteries. And remember, we're talking about neonates, right? So that was complicated. So the arterial switch wasn't developed and didn't become used in the U.S. until the 80s, and in some places in the U.S., especially in the South, until the late 80s, early 90s. So let's see how Jatani performed this. So the arterial switch operation involves the division of the aorta and the pulmonary artery, and with a maneuver called the Lecomte maneuver, flipping them to the right position. So I have a quick video to show you all here. As you can see here, it involves the creation of coronary bottoms and reimplantation. So that's something to take into account. Okay, let me see. I did have a video there for you all. Well, maybe later. Okay. So, as I told you, because of this coronary technicality and the difficulties, the arterial switch wasn't available until the 80s, and before that, the atrial switch was the surgery of choice for these patients. So let's think about how did they came up with the atrial switch. So since we couldn't fix the great arteries here, since we couldn't fix this piece, then these very smart surgeons determined that it was more feasible to redirect the flow from the RA to the LV that was connected to the PA, and redirect the flow from the LA to the RV that was connected to the aorta. Oops. Okay, there you go. The big problem we're left with, with the atrial switch, the blood is going where it's supposed to be going, but the systemic ventricle is the right ventricle. And as you all know, the right ventricle is not designed to pump at systemic pressures, and that brings a lot of trouble down the line with RV hypertrophy, RV dilation, systemic tricuspid valve annulus dilation, and systemic TR. Okay, so this is what the atrial switch procedure looks like. So as you can see here, it involves the creation of baffles. So the SVC and IVC that were connected to the RA are redirected by these baffles that look like trousers to the mitral valve in the subpulmonic LV that is connected to the pulmonary artery. And then let me show you another picture to clarify this. So you can see here these baffles. So this is the systemic venous baffles. We refer to this piece as the SVC limb, and this the IVC limb of the systemic venous baffle. And simplistically, we can say that the space left behind this systemic venous baffle is the pulmonary venous baffle. So you can see, so you no longer have atria per se in these patients. You have two baffles, and that's the nomenclature you should use when you report. This pointer is challenging. So the pulmonary veins draining here, and you can see how the flow will go behind this blue baffle through the tricuspid valve to the systemic RV and to the aorta. Okay, so that's how they work, and this looks great, but doesn't come without complications. So what long-term complications we should look for, and this is just just a summary. There are many more, but systemic RV dysfunction, as we discussed, systemic TR, secondary to dilation of the systemic tricuspid valve annulus, baffle obstruction, okay? Imagine the surgeries are performed in kids who grow into fully grown adults. And there is prosthetic material involved. And so most frequently, the baffle obstructions happen in the SVC and IVC baffles. We also look for baffle leaks which have a clinical implication. They can lead to cyanosis, and also there is some stroke risk associated to baffle leaks. Patients who undergo this huge atrial intervention, atrial surgeries, they can have a sinus node dysfunction, atrial arrhythmias due to the scar tissue, and also pulmonary hypertension. And this is also associated to systemic TR. So this is an echocardiogram, your usual 4-chamber view. As you see, the RV is in the usual position. Here you can see is dilated, and you can see how the LV is much smaller. You can take a peek here at one of the pulmonary venous baffles here, draining into the tricuspid valve. This is what an atrial switch patient looks in short access. You need to obtain sometimes a congenital view, so out of the ordinary views, just to assess the right ventricle from different angles. So here you can see our inflow-outflow view, right? Tricuspid valve, aortic valve. It's a view that we also use in MRI. We use cross-sectional imaging a lot in these patients. This is a stack, a 4-chamber stack. You again can see the same thing we were looking at in echo, a right ventricle in their usual position, severely dilated, dysfunctional, a dilated tricuspid annulus. This is a systemic tricuspid valve with malcoaptation or lack of coaptation, I should say, and then with this patient had severe TR. Here you can see a glimpse of a pulmonary vein as it gets redirected towards the tricuspid valve in the systemic RV. We also need to pay attention to the subpulmonic LV, and very important, I'm not going to show it here, but the MR jet velocity is important to estimate the PA pressures in this patient, so we need to report that. Okay, so this is a patient who was undergoing a routine evaluation, and you can see here this is the subpulmonic LV, the mitral valve. This is the systemic venous baffle, and you can already see here some flow acceleration there. This is a different patient here from the Methodist that we are assessing here. The IVC baffle is very important here, as you can see, to appropriately look for gradients and trace them. And remember, these patients get an echocardiogram once a year sometimes, and the whole purpose is to screen for this, right? We've had a patient, for example, whose IVC baffle was not well imaged for many, many years. It was not well seen in echocardiography. When you cannot see it, you need to find an alternative imaging modality. And when undiagnosed with IVC baffle obstruction for many, many years and developed liver cirrhosis, by the time it got diagnosed and stented, it was too late. So this is one of our patients who's undergone heart and liver transplantation. So very, very important. We like to meet these patients earlier than in the transplant evaluation phase. This is an image of the pulmonary venous baffle, that the same we were looking at with MRI. Again, very important to look at spectral Doppler and trace for the gradients. So how do we look for baffle obstruction and leaks too in an MRI? So we like our axial stacks. So we perform an axial stack across the atria, and just looking for for patency of the baffles and jets, leak jets. So you can see this is an axial stack going from superior to inferior. You can see the aortic arch here, the azygos, the SVC. Let's just follow the SVC here down, and we can see the systemic baffle here, narrow there, and then the IVC baffle right here. And we also obtain a special series, a modified bicaval view, where we see the SVC and IVC as they enter. I'll show it to you in a minute. CT is very helpful too for the evaluation of baffle obstruction. Remember, it's also in patients that cannot undergo MRI. And you can look for calcifications. It's also very helpful for ablation planning to see sometimes, as you know, with a catheter in a mastard or a stenting, you will get into the systemic vein of the baffle, and if you need to get to the pulmonary veins, you need to cross the baffle, and it's good to know where the calcifications are and so forth. Oh, so this is a patient who had a stenosis of the superior and inferior limb. Here is an MRI showing the inferior limb stenosis right there, where you see the arrow. And we obtain a very similar image from the SVC as well. It's important because this stenosis can be stented. This is an example here, a patient that got both limbs stented. And then let's look at the other potential complication are the baffle leaks. You can see one very, very clearly here. And the flow here is going from the pulmonary venous baffles to the systemic venous baffle. That in here, you can see the mitral valve here. And here is the way we see them in MRI. You can see this one very clear here. Sometimes they're very small and harder to see. It's not infrequent to find them at the suture, the SVC, the superior limb, because as you know, there are pectinate muscles, so the suture lines sometimes are not as tight. Very important to assess the systemic tricuspid valve in atrial switch patients in masters and stentings, and we should use everything we have available: 2D, color, spectral Doppler, 3D. This is 3D imaging of the systemic tricuspid valve, and this is one of our patients who has significant systemic tricuspid valve regurgitation, as you can see here in 3D imaging and color. So the guidelines, the ACHD guidelines, recommend that these patients are imaged annually with echo or CMR for common long-term complications, and then that we need to look for leaks, as we discussed. And remember, these patients have conduction issues, so many of them will have, to complicate matters further, they will have leads, pacemaker leads in this, going from the SVC through the systemic venous baffle to the subpulmonic LV. So, imaging annually, as we discussed, MRIs, cross-sectional imaging, MRI and CT frequently, depending on how sick they are, as close together as 1 year apart. So let's move on to our arterial switch operation. This is our Brazilian surgeon that pioneered the surgery. And what happens here is that these patients, after the arterial switch, are left with a systemic left ventricle, which has shown to have a lot of benefits. The majority of these patients are in their 30s or 40s. 30s and 40s, so we don't have longer term data than that, but they do very well. So we just need to look for some complications. They also need imaging and for close follow-up. So as we discussed, this is the video I wanted to show you. I recommend you all, this is from Cincinnati Children's. I love this video, I show it to all my fellows to understand the arterial switch operation. So I don't know if
are separated from their roots for planned movement.
I'll just explain it to you. So the aorta and the pulmonary are separated, and then coronary bottoms are created here because, as you know, they need to come from the systemic ventricle, and then the pulmonary artery is moved anteriorly. This is called the Lecombe maneuver. So let's just look at the coronary bottoms. So this is a critical portion of the surgery. Remember, these are infants that are getting the operation. So then the pulmonary artery, which was arising from the LV, is moved anteriorly to the RV, and they're both sutured back. So as you can see, we need to monitor for coronary stenosis down the line. We need to look at the suture lines for stenosis. This valve, the aortic valve used to be the pulmonary valve, so we need to monitor for regurgitation and root dilation. But this is what the arterial switch entails. As you can see, when you move the pulmonary artery anteriorly, you're stretching the branch PAs, you see, anteriorly. So we need to also look for branch PA stenosis, very important for you to know as you're taking your exams. Let me just move on. Okay. So this is one of our patients who had an arterial switch operation, very similar 3D reconstruction. You can see the pulmonary artery anterior to the aorta. I tell the fellows that it's like hugging the aorta backwards. You can see how the branch PAs can be stretched. They used to be posteriorly, and you're moving them anteriorly. So we need to look for that. We need to assess for the RV systolic pressure. To screen for this, and in echo we need to assess for the pulmonary arteries. The advantages of the arterial switch is restores the LV as the systemic ventricle, big advantage. Now has low operative mortality. In the 80s that this was not the case, so it was a tough transition. And they have it has good short and midterm results. We need more long-term data. So this is a usual arrangement, right? Normal anatomy as you usually see it in the MRI lab, the aortic root and the PA here. This is an arterial switch, right? You see the root here and the branch PAs that can be stretched. This is a good-looking, these are good-looking branch PAs. I'll show you another one that in contrast, you can see here flow acceleration in MRI. So this patient had branch PA stenosis. Sometimes a stent can help. Remember, this is a mechanical thing. So we also look at a branch PA flows on MRI. We measure the flow in each branch PA, and we report the differential flow. We need to remember this used to be the pulmonary valve, now in the aortic position, so these patients can develop neo-aortic root dilation and neo-aortic regurgitation. So we look for that. This patient has some neo-AR. So the arterial switch has great outcomes and is the surgery of choice these days, but we still, these patients, they all need lifelong care, and they need serial imaging with echo and CMR, and we look for all these complications that I just told you about. We perform anatomic evaluation of the coronary arteries just because they were instrumented, reimplanted, especially in patients with symptoms that are concerning. And sometimes myocardial perfusion can be helpful too when patients present with symptoms. Okay, just let me look at my time. Okay, so let's talk about the very last operation. So the Rastelli operation, not all patients with D-loop transposition get one. In general, this is performed in patients who have VSD and also pulmonary atresia or severe pulmonary stenosis, patients that need a conduit, okay? So patients who have pulmonary atresia, as you can imagine, they will need, we cannot do an arterial switch because the atretic pulmonary valve won't serve as well as a neo-aortic valve. So they need a conduit that connects the RV to the PAs, and then the VSD is closed in a way that the LV flow is redirected to the aorta. Okay, so the Rastelli involves a VSD closure in a way that creates a baffle, right? We redirect flow to the aorta from the LV. So the LV is the systemic ventricle, and a conduit is placed from the RV to the PA. We discussed this. What are the advantages? The systemic ventricle is the LV, so that's great. A conduit that is placed in childhood usually needs to be upsized several times as the kid grows. So these patients will come to our ACHD clinic after 2 or 3 reoperations just to upsize the RV to PA conduit. And then we have an LV to aorta pathway, the baffle, right? And this needs to be monitored for stenosis. Some patients can have residual VSDs, though infrequent. And also it has been described that there can be VT related to scar. So here, this is a stack of images. I'm just trying to show you what I'll show you in the pictures there. So this is the LV, and this is the baffle to the aorta. You see, the VSD was closed in a way. If we closed it anatomically, this wouldn't work, but it's closed in a way that the aortic flow gets redirected to the aorta. The LV flow gets redirected to the aorta. Let me show you here. So LV, and this is the baffle here. You see, it's unobstructed, looking nice. And then we discussed that there is an RV to PA conduit. So this is what I'm trying to show you here with this stack. Sorry. Right here. So this is my conduit here. You can see there is a stent there. Okay, so just to close, as usual, I think I always say the same things. Information matters, native anatomy, surgical reports. This is a purposeful imaging. We know what we're looking for, and we go and try to get it. If that one modality doesn't work, echo, the windows are limited. MRI, they have a device that creates a lot of artifacts. Then we go to CT, so we get our answer. Our patients don't leave without knowing that the baffles are patent, that they don't have leak, without estimating the systemic tricuspid valve regurgitation, the RV, systemic RV function, branch PA, stenosis. A lot of times we combine modalities to answer all these questions. When the anatomy is complex, confusing, in all complex congenital heart disease, obtain an axial stack and sometimes a coronal stack or a 3D navigator. We do that routinely for our congenital patients. It's really helpful to have a 3D stack of images that we can go back to and answer specific questions, especially when you're planning surgery or transplant. And always look for these issues, complications, and associated defects. And with that, I'm going to finish here. Does anybody have any questions? My fellows get usually intimidated by the camera and the broadcasting.
Anytime on the Rastelli operation when they have to upsize
Yes.
conduit, each time the patient has to have their chest open, it's open heart. Right?
Yes, yes. Yeah, so that's why patients get a conduit only when they need it, right? Only when there is no other alternative. Yes, but yes.
The same pathology, but sometimes there is atresia in the tract.
Right. That's right. Imagine that we discussed that for the arterial switch operation, right? We use our pulmonary valve as our neo-aortic valve, right? Because the valves stay in the same place. We just switch the great artery. So that the former pulmonary valve is now serves as your neo-aortic valve. So you need a good sized and normally functioning pulmonary valve in order to perform an arterial switch operation, right? So in patients with pulmonary stenosis or even pulmonary atresia, then you will need a conduit there, right? And since you're committing this patient to a conduit and they have a VSD, you close the VSD in a very smart way that you redirect the flow. So you have a conduit, but you have a systemic left ventricle. So that's a positive side of the Rastelli. So it's a minority of the patients who get that. They have to have these anatomical characteristics to be eligible for it. Yes, Amber. Well, you know, just what needs to be taken into account here when we're thinking with our adult cardiology hats is that these are kids. So prosthetic valves in small kids, they also outgrow them, right? So they're not usually used in kids, right? Yeah. When you need a new valve, usually homografts are usually your options. Yeah. Yeah. Yeah.
So with the systemic venous baffle, so there's a IVC limb and there's an SVC limb.
That's correct.
So the coronary sinus will be considered drainage?
Oh yes, that's a great question. Yes. So where does it go? You're asking, or?
So this coronary sinus drainage never considered in the baffle.
Y
So will this be considered or just be ignored?
Yeah, well, it's let's just say that we account for it. Yes, but it doesn't get redirected. Yes, if that's yeah. All right. Well, we here in the south of the U.S. we see a lot of patients with mast stars in some settings because the arterial switch was not performed here as soon as it was in the East Coast, so it took longer. The mortality initially was high, so there was some hesitancy. Now it's good. It's easy to make the decisions now that we know what's going to happen. But back in the day, parents or surgeons needed to, in the 80s, needed to decide between a mastard that the outcomes were established. You knew what was going to happen. You knew the complications too. And a newer operation that you didn't know the outcomes, and that at the very beginning, until surgeons got the expertise that was needed, had a higher mortality. So it was a challenging transition in medicine. But I'm glad they did it. So yes, so the survival is really good. The great majority of these patients make it to adulthood. So we see these patients in ACHD clinic all the time. The arterial switch started in the 80s, late 80s, early 90s in some areas of the U.S. So the patients are really young. They're in their 30s and 40s. So very young. So we don't know, in their 50s and 60s, and but in general the outcomes are really good. And for the atrial switch, we see many of them so they usually have a good lifespan. They go into adulthood, but then in the 30s, 40s, 50s, there is systemic RV dysfunction. So we see a lot of these patients for transplant evaluation. Some of them, the important thing to take into account is when you're thinking in congenital heart disease, it's always hard to pull the trigger of transplant referral, but it's important to do it before they develop significant pulmonary hypertension. So these patients have systemic TR, and the pulmonary pressures gradually increase with time. So that needs to be very closely monitored, because then you're left with a patient that needs a heart and lung transplantation, and we have those too. So it's better to, when you think about timing, to do it before that. Yes. All right. Well, thank you so much. Oh, yes. Thank you. Thank you for your attention. Thank you, Salim.